Yeah, first of all, I would like to thank the organizers and the chair people to invite me to this meeting and given me the opportunity to talk about philosophy of LAA appendage closure. I think it's a very challenging task to do that. Since I'm not an educated philosopher, I try to do my best. Okay. Yeah. One second. Here we go. These are my conflicts of interest. And to start with philosophy, all men were created equal, except the LAAs. And I owe these pictures Professor Meyer from Bern. And we have seen the excellent presentation of the anatomical details in the morning by Andrew Cook. And on the other hand, all devices for LAA occlusion have the same purpose, but they were designed differently. So the first here was Aprivia's Plato, second was the Watchman, then came the cardiac plug. Also, some of the corax wave crest have been implanted. The same is true for Teresideris, CMD patch. Cardia has developed a device, and also Occlutech. I'm not aware of other devices, but probably there will be a bunch of different designs around in the near future. So far, a balloon, a parachute, and a pacifier design have been investigated in clinical trials. The balloon is Plato, the parachute is Watchman, and the pacifier is the ACP. And these are the only devices so far where we have reliable data. And when one looks at the design of these devices, they all contain nitinol frames, they have membranes, they come in various sizes, and they all have hooks. They require big sheath for application. They are retrievable before they are unlocked, and repositioning is possible. So if you look at this picture, you see that the sizes are comparable, 7, 5, or 8 different sizes. The caliber of the sheath is 9 to 14 French. The Plato had 32 hooks, the Watchman has 10 hooks, and the ACP has got 6 pairs of hooks. And now one can say that none of these devices requires or required oral anticoagulation, because the ASAP data have been released by the mid of May 2012, saying that also after Watchman implantation it is safe not to use oral anticoagulants. Sizing, placement, stability test, and unlocking of the occluder follow the same principles. The landing zone has to be sized either angiographically or with echo. The placement through a big sheath and the stability test and also the unlocking follow the same technical principles, although the details between the systems are varying. The acute results also are comparable for all 3 occluders. You have heard the data in detail already. I would like to show you where I took the data from. 3 Plato papers, 2 Watchman papers, and 2 ACP papers. And I would like to draw your attention only on the implant success. It's between 92 and 98%, so we would probably never approach 100%, but it should be well over 90. And we have to tell our patients that this procedure considers a risk of around 5 to 7% that something happens. And something happens means they suffer a stroke, the device embolizes, or they got a serious pericardial effusion. So that means 1 out of 15 patients will have a problem in most centers, in most hands. But when the device is in place, the patients usually do very well. You have seen the data. Plato beats the expected stroke rate according to the CHUT score. For the Watchman device, a better survival has been found in the PROTECT AF trial after 2 years. The mortality in the warfarin group was higher than in the interventional group. And the same will be true for the ACP, I guess. How can we now pick the appropriate device for an individual patient? I think size matters, and if it's a very large left atrial appendage, it might be wise to use a very large device, a 33 for instance, or a Watchman. If it's a very small one, you will not be able to put a Watchman device into this small hole, so this would be another thing. Proximal lobes are an issue because they all should be covered, and the pacifier design might be advantageous in these cases. Distal lobes are also have to be taken into account, and tortuosity is also a common problem. It can be solved with various approaches, not only with the pacifier but also with a parachute design. And also clots are sometimes a problem, and then you might be happy when you don't have to go too far into the left atrial appendage, and when you can jail the murderer distally in the left atrial appendage. I would like to conclude that hooks, wires, patches, various sizes, and big sheaths seem to be an essential part of a working LAA occluder systems, that so far the steps of the procedure, sizing, placement, etc., are comparable in all systems we have got so far. And no philosophy or design concept has proven to be superior compared to others. With respect to the anatomy of the target structure, it is very unlikely that there will be a one-fits-all device in the future, and thank you for your attention.
So, thanks a lot for this presentation. We will make the discussion at the end of the session.